Now, there are 5 plasmodia that infect humans. First, Plasmodium vivax causes 3D malaria. Plasmodium falciparum, tropical malaria. Plasmodium malariae, 4D malaria. Plasmodium ovale is the cause of 3D ovale malaria. And Plasmodium knowlesi, described recently, was previously pathogenic only for apes. All plasmodia have the same life cycle. Asexual development or schizogony takes place in the human body of an intermediate host, human. And sexual development sporogony in the body of the final host, the female mosquito of the genus Anopheles. Вот получается sexual transmission and asexual transmission in the human body, erythrocyte cycle and exoerythrocyte cycle in the liver. Malaria is endemic throughout most of the tropics. 87 countries and territories have ongoing transmission. The World Health Organization reported then 229 million cases and 409,000 deaths from malaria occurred in 2019. Information before pandemic, dear students. There is a decrease from 239 million cases in 2010, where was 435,000 deaths were recorded in 2016. Over 94% of the burden occurs in the African region of World Health Organization, followed by the 4% of the Southeast Asia region and Western Mediterranean regions, with the American and Western Pacific region was contributing the remainder. On the slide you can see a malaria region, dear students. Вот, пожалуйста, у нас Ирак, Египет, да? Вот, пожалуйста, у нас Индия, Бангладеш, and other region of Southeast Asia. According to World Health Organization estimates, India contributes about 70% of malaria in the Southeast East Asian region. Almost annually, India reports about 2 billion cases and 1,000 deaths attributable to malaria. There is an increasing trend in the proportion of Plasmodium falciparum as the agent. There exists heterogeneity and variability in the risk of malaria transmission between and within the states of the country, as many ecotypes or paradigms of malaria have been recognized. The high burden populations are ethnic tribes living in the forested pockets of the state like Orissa, Jharkhand, Madhya Pradesh, ну, подсказывайте, кто мне индусы-то. Chhattisgarh, наверное, and the northeastern states, which contribute bulk or morbidity and mortality due to malaria in the country. Нет индусов. According to the World Malaria Report 2017, in the year 2016, more than half of the population, almost 700 billion, was at risk of malaria. India accounted for 6% of cases in the world, 6% of the deaths, and 51% of the global Plasmodium vivax cases. More than half, dear students. The total cases in India are 1.31 billion, with almost 24,000 deaths. On the slide, you can see a dynamic, dear students, decreasing dynamic of malaria. Total malaria cases, Plasmodium falciparum cases, and death from malaria in India. Currently, 50% of the 109 billion population of India lives in malaria risk areas. Of this, 4.2, 32.5, and 33.8% live in areas of high, moderate, and low risk to malaria, respectively. Proportion of Plasmodium falciparum distribution. Так, ну-ка, пониже сделаем. New features, gestures about malaria in India. Resistant to insecticides. Intensive vector breeding grounds created principally by the water reservoir development projects. Urbanization and industrialization. Change in parasite formula in favor of Plasmodium falciparum and resistant in Plasmodium falciparum to chloroquine and other antimalarial drugs. The incidence of malaria in Iraq is low, dear students. Seasonality is from March to November. Prevalence in the north below 1,500 meters. Пожалуйста. Получается South region, dear students, да? Вот. Near to Kuwait. Where there is no risk of the malaria in Iraq. And получается whitish, как это сказать, beige, да? Beige color on this map, where region of Iraq with very low possibility to transmission of malaria. Annually in the Republic of Yemen, about 3 billion people suffer from malaria. More than 60% of the country's population live in a zone of risk of infection. 3 species of Plasmodium malaria have been identified in the country. Plasmodium malaria, 0.2%, Vivox, 2.1%, and Falciparum, 97.5%, dear students. Mixed infection is noted in 0.2% of cases. Вот, пожалуйста. Anopheles mosquito, infected with malaria plasmodia, introduce parasite with their saliva into the human organism while sucking the blood of a healthy person. Sporozoids rapidly disappear out of the blood, travel to the liver and penetrate into hepatocytes, where they develop so-called tissue schizones, which produce large number of tissue merozoites. Tissue of or pre-erythrocytic or ex-erythrocytic phase lasts for 6 days, but in malaria caused by Plasmodium vivax and Plasmodium ovale, some tissue parasites may remain dormant and later become active and be released into the blood. These forms, called hypnozoids, cause no symptoms during 6-11 months or more after the initial infection, but are responsible for late relapses. Epidemiology. The source of the infection is a sick person or a parasite carrier whose blood contains gametocytes. The mechanism of the transmission is vector-borne. Under natural conditions, malaria vectors are mosquito of the genus Anopheles. Or other waves of transmitting malaria are possible. From the mother to fetus or newborn, it's vertical transmission during delivery. Transfusion pathway, dear students, in case of transmission of donor blood containing the pathogen, organ transplantation, drug addiction through a common syringe. Parenteral infection is possible with medical procedures. Pathogenesis. Malaria clinic is caused by erythrocyte schizogony, the growth and reproduction in the blood of asexual erythrocyte forms of the parasite. Tissue schizogony is not clinically manifested. Malaria attacks is associated with the completion of erythrocyte schizogony, mass disintegration of red blood cells, and release in the blood of merozoites and their toxins that cause fever. Due to cyclicity of the erythrocytic schizogony paroxysms, recur every 28 hours in vivox or vale and falciparum malaria and 72 hours of plasmodium malaria. Just a moment, dear students. The human body gets infected with a heterogeneous population of parasites, and schizogony in the initial period occurs asynchronously. Because of this, the fever may be wrong. No, it may be in case of falciparum malaria. In the process of immunity formation, the ability to parasitize in red blood cells remains in one main generation of parasites, which determines the characteristic type of fever. Only in tropical malaria, there can be several, 2-3 major generation of plasmodium, so the fever is often wrong, maybe during some days, dear students. Plasmodium vivox and ovale develop in the reticulocytes. It's young erythrocytes, dear students, you know. Plasmodium malaria in older erythrocytes, but Plasmodium falciparum invades red cells of all ages. Anemia is one of the most common signs of malaria, is a result of hemolysis erythrocytes. Indirect bilirubin increases in the blood and conjugated jaundice is frequently present. In the liver and spleen lymphoid and reticuloendothelial hyperplasia occur. Jaundice develops as a result of hemolysis of erythrocytes and lesions of hepatocytes. Now, the main reason, dear students, of jaundice in case of malaria is hemolytic anemia, hemolysis of erythrocytes. Reduced absorption of carbohydrates and inhibition of gluconeogenesis in the liver causes hypoglycemia. Activation of anaerobic glycolysis leads to lactate acidosis, which is one of the causes of severe tropical malaria. In tropical malaria, the pathogen multiplies in the vessels of the brain, where microthrombose appears. Microthrombosis, dear students, consist of plasmodia, their toxins, destroyed red blood cells, and these formations stick together. Blockage of vessels causes ischemia. Hypoxia develops due to insufficient function of infected red blood cells. The least resistant to hypoxia is brain tissue, what leads to cerebromalaria, its specific meaning encephalitis. Renal failure is a frequent complication of severe Plasmodium falciparum infection with development of proteinuria, hemoglobinuria, and elevated serum creatinine and urea levels. Also, pulmonary edema are due to tissue anemia and hypoxia. In severe falciparum malaria, diasis syndrome occurs. There is a high risk of death in patients with high rate of parasitemia, especially among non-immune persons. Young children and pregnant women are also have a more severe course and frequent complications. After clinical convalescence, relapses may sometimes occur. Late relapses after Vivox and Tuvalu malaria are the result of infection of erythrocytes by merozoites derived from persistent liver forms, hypnozoites. Early relapses are the result of activation of slow asymptomatic erythrocyte cycle. Malaria does not produce long immunity, but if a person lives in the area and is infected with malaria every year, the clinic does not occur. Immunity fades in 5-6 years, and when he returns to the area, the symptoms are as severe as for the first time, dear students. First time. Clinical pictures in your unit. The incubation period depends on the species of Plasmodium and state of the immunity and lasts from several days to several months. Prodromal symptoms are common, from several hours to 2-3 days, and include headache, malaise, fatigue, nausea, myalgia, slight diarrhea, and slight fever, usually not intermittent. Malaria paroxysm includes cold stage, feeling of intense cold, vigorous shivering, and lasts about 15-60 minutes. Next stage is hot, with intense heart, dry burning skin, throbbing headache, last 2-6 hours, and last sweating stage, dear students, with profuse sweating, declining temperature, exhausted and weak after that sleep, and last 2-4 hours. То есть, получается, малярия paroxysm, dear students, can last from 5 hours to 11, да? 11, самый, скажем, такой длинный. On the slide, you can see a different variants of intermittent fever in malaria, dear students. No, Plasmodium vivox is the most common, that is most common. Therefore, dear students, no, almost in all group, I draw this temperature curve. Malaria paroxysm in 3 days malaria takes place on the first day. During second day, temperature is normal and repeats on the third day in 3 days malaria. In 4 days malaria, when causative agent is Plasmodium malaria, dear students, first day malaria paroxysm, on this day, on the получается, end of this day temperature is normalized. During second and third day temperature is normal, and on the fourth day malaria paroxysm repeats. Повторяется, is repeated. And получается, in 3 days malaria temperature will be normal during 48 hours. In 4 days malaria during about 72 hours. And Plasmodium falciparum, dear students, has the severest course, malaria paroxysm can last more than 1 day, maybe during 2 or 3 days. Temperature is normalized and very quickly increases again. After 2-3 temperature attacks, the liver and spleen clearly increase. Hemolytic anemia appears. Skin of the patient has a lemon color, lemon shade, dear students. is hemolytic anemia. And, пожалуйста, features of the Wilkes malaria. The incubation period lasts from 10 days to 14 months. Prodromal period usually lasts up to 5 days. Subsequently, the typical paroxysms develops which last 6-10 hours, ending with profuse sweating. Anemia develops after the disease, but it's not often severe. SR increases. The spleen and liver are often enlarged. However, after 2 weeks to months, early relapses appear, characterized by a synchronous temperature curve, increased liver, spleen, and anemia. Subsequently, with the increase of immunity, parasites disappear from the blood and the latent period begins. During this time, schizotrophic drugs are not given. Then in 6-8 months, and sometimes after 1-3 years, the activation of slumbering tissue forms of the parasite or hypnozoids, and later relapses develop. Oval malaria. The incubation period usually lasts 16 days, but may be longer, from 2 months to 2 years. Oval malaria is usually characterized by slight clinical symptoms. Paroxysms frequently develop in the evening and are not severe. For this form, early and late relapses are common. Falciparum malaria. In most patients, tropical malaria begins acutely, without a prodromal period, with a rise in body temperature up to 38, 39, and more, up to 41 degrees of Celsius. In some cases, the onset of tropical malaria is accompanied by nausea, vomiting, and diarrhea. Cultural symptoms from the upper respiratory tract sometimes are registered. In the acute stage, patients have conjunctival hyperemia. In severe course, it can be accompanied by petechial or large subconjunctival hemorrhages. The fever lasts for days. Periods of hyperexia are rarely recorded. The duration of individual paroxysms, and in fact the combination of several ones, with tropical malaria reaches 30-40 hours. The long time of temperature curve prevails, less often the remitting time is observed, occasionally intermittent and constant ones. Enlargement of the liver and spleen is usually determined from third day of the disease. More than a threefold increase in the activity of immunotransferase is regarded as an indicator of an unfavorable forecast. In falciparum malaria, a great number of erythrocytes, as a rule approximately 20-30%, are infected. In this form, severe normocytic anemia, thrombocytopenia, and decrease in hemoglobin are common. The recurrent course is due to inadequate etiologic treatment or the presence of Plasmodium falciparum resistance to chemotherapy. The natural course of tropical malaria with the favorable outcomes lasts more than 2 weeks. In the absence of idiotropic therapy, relapses occur after 7-10 days. Pregnancy and early childhood are risk factors for severe tropical malaria. Children under 3-4 years don't have the most striking symptom, malaria paroxysm. Symptoms such as cramps, vomiting, diarrhea, abdominal pain are observed, with a progressive deterioration of the child's condition. Parasitemia is usually high. The disease can quickly acquire a malignant course, and lead to death of the child. Complications. First, cerebral malaria, dear students. Undroseable coma, not attributable to other cases. Generalized convulsion, dear students. Severe normocytic anemia. Hypoglycemia when blood glucose less than 2.2 millimeters per liter. Fluid and electrolyte disbalances up to hypovolemic shock. Acute renal failure when volume of urine less than 500 milliliters. Acute pulmonary edema and adult respiratory distress syndrome due to hypoproteinuria. Abnormal bleeding, jaundice, hemoglobinuria, circulatory collapse, toxic shock, septicemia in case of algae malaria. And sometimes maybe rupture of the spleen when size of the spleen is huge. Cerebral malaria. I described some complications, dear students. Develops in Plasmodium falciparum. Plasmodium multiply in the blood vessels of the brain where they disrupt the blood circulation. The onset of coma may be preceded by headache, drowsiness, stupor, or excitation. The patients become unconscious in a comatose state. Various neurological signs may be present. In untreated cases, mortality reaches up to 100%. In case of treatment issues, mortality is 95%, the severest infection. Black water fever. Black water fever develops due to massive intravascular hemolysis in intensity of infection or in treatment with some anti-malaria drugs. Intense jaundice, severe hemorrhagic syndrome, anemia and anuria develop, accompanied by chills, fever up to 40 degrees centigrade, low back pain, vomiting, myalgia, and arthralgia. Вот, пожалуйста, доктор. Normal color of urine patient and dilated. Urine becomes dark brown or black due to the presence of oxyhemoglobin. The number of red blood cells decreases up to 1 per liter and hemoglobin 20-30 gram per liter. Parasites in the blood may not be determined. With the rapid abolition of antimalarial drug, the condition improves. In severe cases, the prognosis may be unfavorable due to the development of acute renal failure. Renal failure, dear students, is develops due to the reduction of interrenal blood flow and microcirculation. Renal damage is manifested by increasing creatinine and urea in the blood. Uremia and coma may develop. Но renal failure, dear students, usually, скажем так, is mixed with toxic shock, for example. Diagnosis. You should know, dear students, epidemiological and clinical data. Microscopic examination of thick or thin blood smear. The thick drop contains more blood, толстый мазок, more blood, therefore the probability of finding plasmodium is much greater than in the smear. Rapid diagnostic tests are quick tests that use a drop of blood from the fingertip to identify whether parasites are present in the patient. PCR for determination of parasite DNA. On the slide you can see erythrocytes with Plasmodium falciparum, dear students, vivox, ovale, and malaria. In case of ovale malaria, malaria ovale twins, erythrocytes, скажем так, change their shape and looks like oval. Treatment, dear students. Please group number 28, 29 read in our chat. 28 and 29 write in our chat. Hematoschizotropic drugs affecting erythrocyte schizones, chloroquine, mefloquine, quinine, artesunate IV, artemether IM, artencir with lumefantrine or amide, pyrimethamine with sulfadoxine or fansidar is prolonged sulfanilamide, students. Next group, histoschizotropic drugs, infecting pre-erythrocytic or primary tissue forms. Pyrimethamine, proguanil with atovaquone or malaron, affecting exoerythrocytic or secondary tissue forms, primaquine, dear students. Now, dear students, in Russia there is a problem. We don't have primaquine. For prevention of relapses of malaria in Vivox and ovale malaria, primaquine is absent now. Next group, gametotrophic drugs affect sexual forms. Gametocyte, primaquine, gametostatic, pyrimethamine or sporontocyte action. And four group students is antibiotics, doxycycline and clindamycin. Treatment Plasmodium vivox, ovale and Plasmodium malaria. Drugs such as chloroquine and primaquine are recommended. 10 mg per kilogram per day at first and the second day. During the third day, 5 mg per kilogram per day, chloroquine or primaquine. Currently, Plasmodium has resistance to quinine preparation. Therefore, artemisinin and its analogs are recommended. For radical care, dear students, prevention of long-term relapses in malaria caused by Plasmodium vivox and ovale, at the end of the course of chloroquine, a tissue schizontroside is applied, primaquine, which is prescribed for 14 days at a dose of 0.25 per milligram per kilogram base per day. About treatment of Plasmodium falciparum. If non-immune Plasmodium falciparum is found in the blood, in cases of a mild and uncompleted course, treatment regimens with artemisinin combined antimalarial drugs are used in accordance with World Health Organization recommendations. Two or more antimalarial drugs with a different mechanism of action are used. Furosemide, atovaquone, 1,000 milligram proguanil, 400 milligram one time a day. Pyros during 3 days. Artesunate 4 milligram per kilogram one time a day during 1 day. Or sulfadoxine 25 milligram per kilogram or pyrimethamine 1.25 milligram per kilogram one time a day. Pyros during 7 days. Artesunate 2 milligram per kilogram one time a day or doxycycline 3.5 milligram per kilogram one time a day. Pyros during 3 days. Artesunate 4 milligram per kilogram one time a day during 2 days. Mefloquine one time a day. First day 15 milligram per kilogram, second day 10 milligram per kilogram. Pyros during 4 days. Artemether 80 milligram one time a day, then 80 milligram every 8, 24, and 48 hours from the moment of the first dose during 2 days. Lumefantrine 480 milligram, then 280 milligram every 8, 24, and 48 hours from the moment of the first dose. On the slide, you can see some drugs for treatment, dear students. Primaquine, dear students. Histotropic drugs. Вот, пожалуйста, primaquine. Please, student group number 26, 25, write in our chat. In the countries of Southeast Asia, where poly-resistant strains of Plasmodium falciparum are common, they use artesunate with mefloquine, artemether with lumefantrine or coartem. If the patient has not established the type of pathogen, then treatment is recommended according to treatment regimens for tropical malaria. In severe and complicated tropical malaria, the treatment of choice, according to the recommendation of World Health Organization, is artesunate in drip for 7 days. First dose 4 mg per kilogram, then 7 days 2 mg per kilogram per day, and quinine in an alternative drug for the treatment of severe falciparum malaria and is used in the absence of artesunate. Quinine is used intravenously in a 5% solution of dextrose or glucose or isotonic solution slowly, 10 mg per kilogram for 4 hours, then 20 mg per kilogram per day for 2-3 injections with an interval of 8-12 hours. Daily dose for an adult should not exceed 2 grams. With a subsequent transfer of the oral form of the drug. Quinine monotherapy doesn't provide a radical cure, since it's rapidly excreted from the body, and its long-term use often leads to the development of adverse reactions. Therefore, after improving the patient's condition, they are treated with mefloquine, fansidar, or tetracycline. Вот, пожалуйста, доктор Fansidar. IV injection and in tablet. Prolonged sulfanilamide. And diagnosis example, dear students. Diagnosis of your patient from India, да, в основном, конечно, will be so as tropical malaria, account of Plasmodium falciparum. Plasmodium falciparum 124,000 parasites in 1 microliters, and complications cerebral form and common.